Good evening, Dr. Praveen. Dr. Kaul is there?
So just joining soon.
Okay, very nice. Yashwant Chaudhary.
Hello, sir.
Dr. Anuja Patil is one of the.
Yes, I am from KIMS team only. Yes, sir.
Huh?
Good evening, sir.
Good evening. Very nice. Good. And Yashwant is a resident. Yashwant
Yes.
is a,
Resident at KIMS Hyderabad.
very nice.
Hello, sir.
Good
Good
evening.
evening, everyone.
Good evening.
Good evening,
Hi,
sir.
Sripad. How are you?
Sir, you can start.
Hello, Aish.
Sir.
Hello,
sir.
Manish. Hello, Yashwant again.
Hello, sir. Good evening, sir.
Sripad sir, we can start. So
Okay. Have Praveen or Anuja have also joined? Are they there?
Yes, sir. Yes, sir.
Oh, hello,
Ready.
hello, Anuja.
Good evening,
Those
sir.
of you who don't know, Anuja is a very eminent
Sir.
immunologist, neurologist presently in Mayo Clinic.
Wow.
But
We'll
she'll come
start,
back,
sir.
hopefully. Hopefully.
We
And Praveen is there or he'll join. So I think, are you sure to start it? What is the format?
Sripad sir is here, sir. He'll start, sir.
Okay, Sripad, please, over to you.
Yeah, you start.
Okay.
No problem. You
Uh,
can begin.
Thank you everyone for joining. So we are here with another webinar from the Autoimmune Disorder subsection of the Indian Academy of Neurology. And we have an interesting case that is being presented from KIMS Hyderabad. And I will, without further ado, hand it over to Dr. Yashwant Chaudhary to start with the case. For moderation, we have Dr. Subhash Kaul, who needs no introduction, from Hyderabad, and Dr. Manish Mahajan from Gurgaon, both very eminent neurologists, neuroimmunologists. So over to you, Dr. Yashwant.
Good evening, everyone. Good evening, teachers and IN. Thank you for giving me this opportunity. So today we'll be having a relapsing brainstem syndrome. Coming to the case, we have a young lady, 27-year-old right-handed individual from Hyderabad, first of the two siblings born out of non-consanguineous marriage. Currently, she's at home after discontinuing her MBBS. Informant being self as well as mother, who are reliable. So she presented to us 1 week back with episodes of imbalance while walking, incoordination of the limbs, double vision, slurring of speech, deviation of mouth to left side, ringing sensation of the left ear for past 13 years, and blurring of vision for the past 12 years. Yes, sorry. So apart from this, history of present illness revealed she was apparently all right till 2013. That is, at the age of 15 years, the first attack has happened, which was double vision, which was sudden onset binocular double vision that disappeared on closing one of the eye. That was progressed over next 5 days. It was not painful, no blurring of vision, no diminished vision, or any drooping of eyelids was there. Ringing sensation in the left ear was there, which was intermittent. It was non-pulsatile, no pain, no hearing loss, no fullness of ear, and there was no history of loud noise exposure prior. Imbalance while walking, which was sudden, and severe swaying with wide-based gait with tendency to fall, along with incoordination of limbs, which was more on left side. There was no worsening in dark or eye closed, no spinning sensation, no nausea, weakness of the limbs, no stiffness, dragging of legs, any sensory paresthesias, sphincter disturbances, or any drug intake. There was face asymmetry with angle of mouth deviated to left side. There was no difficulty to close eyes, loss of taste. Slurring of speech was there, which was sudden difficulty in articulation with hypernasality, with normal comprehension. There was no aphasia, no hoarseness of voice, choking, or any fatigability. There was no history suggestive of altered sensorium, seizures, headache, diminished vision, abnormal sensation on the face, no choking or regurgitation, no limb weakness, no worsening with heat or exertion, no sphincter disturbances were there. And no history of fever or any recent vaccination, no systemic features like fever, rash, arthralgia, dry mouth, dry eyes, oral or genital ulcers, or uveitis. No previous transient neurological symptoms. There was no history of TB, no history suggestive of malignancy, and there is no relevant family history, any medication or drug history. So these complaints almost remain more or less the same with some progression until she sought medical aid, which will come to the next. So I would like to analyze these symptoms and localize the first attack because there were around 18 attacks over the next 10 to 12 years. So the first attack, it is binocular diplopia, likely at pons, abducens nerve or MLF, left ear tinnitus, which could be at CP region, auditory fascicle or nucleus, gait imbalance at vermis, limb incoordination left more than right, localizes to cerebellar hemispheres on left side, face deviation which was unilateral at pons, facial nucleus or fascicle with slurred speech, bilateral cerebellar hemisphere. A short summary and localization of the first episode. 15-year-old girl presented with acute onset of bilateral diplopia, left-sided tinnitus, gait and limb ataxia with facial asymmetry and dysarthria. Left pontine region with cerebellar and connections would be the localization. So subsequent attacks from 2013 to 2016, as we have just talked about the first attack, it happened in November 2013 at the age of 15 years. Possibly the clinical diagnosis was phenotype, basically it was brainstem syndrome. Possible differential diagnosis which were thought were inflammation, MS first attack, NMO, MOG, CNS vasculitis, neurobeshet's and CNS lymphoma. So she was evaluated with MRI brain at that time. T2 flare hyperintense lesions were found at pons, left MCP, cerebellum, which were non-contrast enhancing. So they were suggestive of demyelinating lesions. Possible differential diagnosis thought were demyelination, infectious Lyme's disease, and vasculitis. Treatment at that time, IV pulse steroids over 5 days were given, after which she showed a significant improvement, around 80% improvement, with some gait ataxia and tinnitus. In 2015, it was the second attack at almost 1.5-year gap was there. Attack number second and third, which were within a gap of 4 months with gait ataxia, diplopia, and tinnitus being her clinical issues. Diagnosis, again, it was thought demyelination and vasculitis. A repeat MRI was done at that time. T2 flare hyperintense lesions at pons, left MCP, and cerebellum, suggestive of demyelinating lesions. Again, she received pulse steroids followed by oral steroids along with MMF was started because partial remission. And the fourth attack was in 2016 at the age of 18 years. At this time, she had a new complaint, that is blurring of vision in bilateral eyes, which lasted for 5 days. As such, there was no pain along with this blurring of vision. So clinical diagnosis, we thought it could be demyelinating MOG, we have included in this, and NMO. Vasculitis, Behçet's, neurobeshet's was also thought. As there was blurring of vision, BEP was done, which suggested it was not recordable. MRI brain and spine was done again. Demyelination was there in the left MCP and cerebellum. There were no cord lesions and there is no contrast enhancement of these lesions. She partially improved with IV pulse steroids, almost we can say around 60% what she told. Along with oral steroids, MMF and maintenance azathioprine was initiated at this time. Subsequent attacks in 2017 and 18. 17, she had multiple relapses and these relapses were disabling her daily life. Clinical diagnosis thought was some demyelinating lesion was ongoing, which was resistant, along with some vasculitis was thought. So HLA B51 was sent, which was positive. So neurobeshet's was considered and cyclophosphamide was initiated. 7 monthly cycles of cyclophosphamide were given, but despite of that, there were persistent relapses. Attack number 8, 9, 10 also, they have the similar clinical phenotype, double vision, visual blurring, severe ataxia, and severe gait ataxia. Almost all of them responded partly to IV steroids. And attack number 11, 12, she had around 3 relapses within September of 2018. And highly active relapsing disease was thought and extended autoimmune panel was sent. Serum MOG, ELISA was strongly positive at that time. Aquaporin 4 and OC bands were negative. So rituximab was initiated at that time. Around 8 cycles of rituximab she received. But despite of that, she continued to have these all relapses. At the age of 22, in 2020, she started to have dysarthria, which was strained, effortful, explosive in quality, and some pseudobulbar features like emotional outbursts, inappropriate laugh, and crying have been started. So again, she had relapses despite of rituximab. So a repeat serum MOG was done, which revealed high titers, and MRI brain was done, which showed significant atrophy of brainstem at the site of lesions. So at this time, tocilizumab was initiated. 9 doses were given within a span of 2 years. But despite of those 9 doses, she continued to have relapses. At that time, the last relapse, what she told was in 2022, and family got fatigued because of these relapses, and they have stopped visiting hospital since 2022. The current visit, that is in 2026, she presented with blurring of vision, which was 5 months ago, and that lasted for around 2 weeks. And without any treatment, it got improved. So at present, after a gap of 4 years, family seek re-evaluation. So these are the MRI images what we could retrieve. MRI T2 flare intensity involving the bilateral cerebellar hemisphere in the peridentate regions, as we can see here, along with MCP. I'll just zoom in. So we can just see peridentate hyper T2 flare hyperintensity is noted here, along with the right MCP and optic nerve on the right side, on the right as well as left shows T2 hyperintensities. Even here we can appreciate the dentate and cerebellar hyperintensities. And this is the contrast image. In contrast, there is no contrast enhancement of the below images. And this is in 2018. We can clearly see T2 flare hyperintensities involving medulla and medulla, pons, bilateral cerebellar hemispheres, peridentate region. Even at superior cerebellar peduncles were also involved in this. And gross atrophy we can see in this image. And as well as in 2018, these lesions are not contrast enhancing. And this is in 2019. Even we can see that atrophy has still increased. Here we can see that atrophy of the pons, significant atrophy at the level of pons, and brainstem atrophy. And never there was any cord lesions. And this is the last MRI, which was in 2022. So we can see T2 flare hyperintensities is involving medulla, bilateral cerebellar hemispheres, pons, MCP levels, bilateral, and superior cerebellar peduncles at this stage, and significant atrophy is also noted. So other relevant investigations which were done during the course of illness were BEP, which was non-recordable. HLA B51 was positive in 2017. MOG antibodies by ELISA, high titers were noted in 2018 and 2020. So other relevant tests which were negative are CSF OC bands, CSF routine CSF, which was done almost 8 times. It was unremarkable. NMO was negative, ANA profile, ANCA, ESR, CRP, all of them were negative. TB workup was negative, skin pathology test was negative, serum AS was negative. So differential diagnosis, what we considered are demyelination, possibly MOG disease. Supporting features were pediatric onset with brainstem involvement. Against which there was no encephalopathy. Demyelination, NMO was suspected, brainstem involvement, but there is no myelitis, no area post-traumatic complaints. Autoimmune neurobehcets was suspected with brainstem predilection, but there were no other clinical features like orogenital ulcers, any uveitis, or skin pathology test was negative. Treatment summary: overall, she received IV solmetrol, methylprednisolone almost in each cycle with partial response with oral steroids on a long-term basis. MMF and azathioprine were also used on a long-term basis. Cyclophosphamide, she received 7 cycles with poor response. IVAG around multiple doses were given. Rituximab around 8 cycles were given at 6 monthly interval with limited response, and tocilizumab around 9 monthly doses. General examination at present in 2026 revealed conscious, coherent, cooperative, well-built, nourished, hygienic, and well-mannered with hemodynamically stable state with higher functions. MOCA only, it was 28 out of 30. She's emotionally labile, inappropriate crying, excess laugh, slow, effortful, strained, explosive, impaired articulation was there. Cranial nerves, optic nerve, pale optic disc, bilateral optic atrophy, RAPD was present, visual acuity 6/6 with glasses, and myopia -2. Upbeating nystagmus was there in primary gaze. Exaggerated jaw jerk, exaggerated gag was there. Rest were normal. And motor system examination, power in the left lower limb was 4-5 with some spasticity. DTRs were brisk. Cerebellar, bilateral cerebellar signs were there. Nystagmus, dysmetria, dysdiadokinesia, rebound phenomenon, truncal ataxia were there. This was the gait of the patient, wide-based gait with truncal ataxia, stiffness of the left lower limb.
Yashwant, what was the CSF? Just remind me.
Sir, routine CSF was done almost 8 times, sir, according to the
Was
documentations.
it
What we
reactive
got.
anytime?
No, sir, it was not reactive anytime, sir.
Never
Proteins,
reactive.
never, sir. TLC, the maximum what we could found were 7 cells, sir.
And even the proteins were never raised.
Proteins were within the range, sir, less than 40 only.
And the only thing, did you ever get a chance to perform mock by cell-based assay?
Cell-based assay, yes, sir. This is the first time the patient visited our hospital. That was only 1 week ago. So we have
Okay.
sent cell-based assay, sir.
Okay. Okay. You've sent that. Okay.
Dr. Yashwant, two questions that I'd like to ask at the same time. One is, was CSF MOG tested in the patient? Because sometimes CSF MOG positivity portends a
No,
more.
sir. Twice it was serum MOG, sir, by ELISA.
And the second query I had is, initially you told in the chart that you'd very beautifully made about the treatment that
Yes, sir.
9 doses of tocilizumab were given over 2 years.
Monthly doses were given, sir. It was initiated in 2020,
So
at the
okay.
end of 2020, sir.
So she was given monthly tocilizumab for 9 months. And did she have a relapse at that point of time?
Sir, at the end of that, she didn't had any relapse, sir. The last relapse, according to the family, was in 2022. So
So at the time that she was receiving tocilizumab, she
Yes,
was
sir.
relapse free, right?
No, sir. Around sixth or seventh dose, she had a relapse, sir.
Okay. And this was monthly tocilizumab, we're sure, because I think during the presentation you said that she received 9 doses over 2 years. That's why I had that specific query.
Yes, sir. It was in, sorry, that was a mistake, sir. It was monthly
Monthly
tocilizumab only.
Okay.
At 6th or 7th episode, she again had a relapse. So family fed up that nothing is happening with all this, and they stopped visiting hospitals.
And the dose of tocilizumab used was?
Documented it was 8 mg per kg, sir.
Okay. All right. Thank you. Please continue.
Yes. So this is a snapshot of total summary of a patient. And diagnosis, what we thought is, it is phenotype chronic multi-site relapsing remitting brainstem predominant disease with secondary progression and residual cerebellar and pseudobulbar deficits, which was refractory to conventional immunotherapy. Complications being steroid-induced osteoporosis with vertebral fracture, pseudobulbar effects, treatment fatigue was done. So at this point, the diagnosis, what we are thinking are MOGAD and neurobeshet, sir.
Dr. Yashwant, just one thing, can we really call it as a secondary progression? Should we use the word progression? Because I think she had multiple relapses and the disability accrual has been due to the relapses.
Yes, sir.
Because because this will change your differentials clinically.
Absolutely.
Sir, probably
No,
the
I think
deficits
Dr.
which might have
Mahajan is very
accrued.
right. I mean, as of now, with aquaporin 4 disease and probably even with MOGAD, it is not considered that these patients go on having this so-called what we call the progressive phase in between the relapses. It would be very difficult, Yashwant, to say that, but because then immediately you would bring this diagnosis into sort of a form of MS, which actually, when you say that there is a secondary progressive phase beginning, I think I agree with Dr. Mahajan that all that she has been progressive, not progressive, accumulation of more and more disability with each and every relapses. I think that's the way we should take. Dr. Mahajan, what do you say?
Yeah. So I think we agree that she has got a multifocal disease. She has a relapsing disorder, partial remissions, initially steroid responsive, and Dr. Ayush rightly mentioned that the best disease modifying therapy till now was tocilizumab for her, because that was the longest interval where any disease modifying therapy at least showed some effect. There is some remarkable, if we just talk about the MRI features, there are certain features which suggest MOG disease, or there are certain features, but there are certain odd features also, like the atrophy which is there. Here, as a learning point, I think which one should also understand is, usually we get an MRI done during an acute relapse, and many of the inflammatory disorders, the actual lesion burden at the time of quantification, when you do it at the time of acute relapse, you will see, because of the associated swelling, the lesion size, and if we do the whole brain volumetry, it will be increased, and if you do an interval scan, the brain can look shrunken. So the atrophy cannot be just commented on the if just compared with the acute relapse MRI. So one point is to be taken into this. But yes, in your case on serial MRIs, there is definitely brainstem and cerebellar folia atrophy is definitely there. So brainstem atrophy is there, which is again very, I think my co-panelists will agree to this, that this is quite remarkable and should pinpoint towards certain differentials.
Yes.
If I can, sir, I think
Yeah,
what
please,
Yashwant
Anuja.
was trying to mention by this progression thing, like the first attack, it was almost like 80% she recovered, hardly sometimes 20% of deficits might have been residual. Early, like every subsequent attacks, there have been kind of a subacute progression, but it does not come down to complete baseline. There was like 60% recovery in the second or third attack, then coming down to only 40%. So like what we are seeing is like there is a buildup of some partial deficits over the time as the attacks went on. So most likely, like he wanted to tell, was kind of a clinical progression with residual deficits, and over these like 13 years, the syndrome remaining only restricted to a infratentorial like system, cerebellopontine system has been noted. And as sir also rightly pointed out, Mahajan sir, like there is significant atrophy quite out of proportion to what her clinical presentation, her age, everything. For a 13-15-year-old girl showing that much of cerebellar atrophy over these many years, and despite being on quite aggressive immunotherapy, went a little ahead, like against of any of the inflammatory disorders. And again, the VEP is being non-recordable. I think it was repeated again during this clinical presentation, or it was the past, like at presentation
The
VEP.
past, ma'am. At present, we have repeated,
Yeah,
ma'am. We have a plan to repeat.
but
Yeah.
So I
visually
think
blurring only and completely unrecordable VEPs, like that much of aggressivity will be a little odd for MOG. And sir told perfectly, like tocilizumab has shown till now at least like 6 months at least she went on without relapses. Despite that, by the end of like 9 doses are good doses for her. Despite that, by 7th or 8th, she did have another attack. So like all these points are going slightly against kind of an inflammatory pathology. So hopefully, like we should be considering this is a young girl presented like in her adolescence with gradually increasing disability despite quite aggressive, like she has almost exhausted all possible immunotherapy options what we have. And
Correct.
so could be any
so.
genetic etiologies also should be kept
Yes.
into differentials, because the atrophy of cerebellum is like quite prominent here.
So, Anuja, thank you. Can I make one point?
Sure, sir, please.
Because there are some 60 people at least who are logging on. That's a great success, Aish. I think there are people who. So I think no. What Yashwant, what Manish raised the point, and Shripad said, but you have to understand what they're saying. This is actually a question of nomenclature, and I think it's very important for us to know that and take cognizance of that. That what is thought is that in MS, even after the acute attack is over, there is a subclinical, progression going on because of the initial thing. That is what is the current thought. I think recently we attended that Mangalore meeting and all that thing. This point was very much emphasized. So in patients like MOG and all, what is thought is that there is, once it recovers that much, but it may not recover completely. So, semantically, there is a difference between secondary progression and accumulated deficits. Right. So, therefore, we won't technically use that term. So, that is the point. Manish, that's what we mean. No?
Correct, sir. Correct.
Yes.
We are
Rightly
not saying
mentioned, sir.
we are not saying that the disability is not progressing, but it is not really slowly progressing. It's accumulated thing. So it is
Correct.
only for so that is what that clarification I wanted. So for attendees who are saying, so technically we have to use, this is, the immunologists take a lot of importance to this, that whether it is secondary progression or whether it is accumulated deficits. Okay. So I think you go on then we'll see.
And Dr. Yashwant, sorry, one of the MRIs you showed the MOG, this optic nerve involvement,
Yes,
although
sir.
it was not a dedicated scan for optic nerves, but one of the
This-
MRI scans you showed. And I think there, so if you see that posterior segment of the nerve is slightly more involved in this although there is in MOGAD the propensity to have bilateral involvement and severe involvement is there. Usually this is not the classical presentation what has been described with MOGAD. So slightly I'm just trying to see if we can have some features in favor and in against the or just a laboratory parameter, which actually honestly speaking, Dr. Ayush is always emphasizing that MOG positivity has to be taken with not with a pinch, with a lot of salt.
Sir, I'll
So,
come to that, but I
so
think uh,
yeah.
Dr. Praveen had raised his hand. I think he
Oh, I
wanted.
think
Yeah,
sorry,
Praveen.
sorry if I
Praveen, go
okay.
ahead.
Yeah.
Please.
There are 2 points. One was the optic nerve involvement, as we classically see in MOGAD. There will around the optic nerve also lot of fat involvement, but we are just seeing a streak within the optic nerve. First point, and the second point, I definitely take about that MOGAD ELISA, but by ELISA they were strongly positive. Just wanted to make this point that in the discharge summary they had mentioned it to be strongly positive, but that was not cell based, but the ELISA. Just these points, just to be fair. That's it.
Right. Thank you. Thank you, Dr. Praveen.
Yeah.
I'd just like to add one thing here. The bilateral MCP involvement is quite classically seen in MOGAD when you compare it to other diseases where you see it amongst
Absolutely.
neuroimmunological autoimmune conditions. It is one of the very few to have a bilateral MCP involvement. Also can be seen in PML in the background of so much immunosuppression that the patient got, but it is bilateral but asymmetrical. This is very, very symmetrical involving the dentate. So that makes PML a little unlikely. What I would be interested in knowing also, since Behçet's was brought in with the background of HLA-B51 positivity, do we have any SWI sequences to see if there was any blooming? Because that would give you an evidence of vasculitis. Because
Unfortunately, we don't have those images, sir.
because here what is important is that for to diagnose probable neuro Behçet's disease, you don't require the classic Behçet's disease criteria to be fulfilled. Patients may not have oral ulcers, patients may not have genital ulcers. The diagnostic criteria states that if somebody has brain involvement which is typical for Behçet's, and as we know that the typical involvement is usually infratentorial, you can say that this patient has possible neuro Behçet's. If along with that, the criteria with recurrent oral ulcers that is greater than or equal to 3 per year, with or without other findings is there, you can change it to probable. But on the basis of what you have described, your patient will fulfill the diagnosis of possible neuro Behçet's. So in that background, SWI imaging becomes an important thing to look at because Behçet's can be very treatment refractory unless and until you eventually go up to TNF alpha inhibitors.
And Ayush, what about optic nerve involvement? Can then happen?
Sir,
Yes,
that has been
yes, sir.
described. Bilateral, that too posterior predominant, we've seen in a few cases. So that since your patient was not responding to anything, HLA-B51 positive, as has been discussed, brainstem predominant,
Atrophy. That is again in
there's
going
so
in
much
front.
atrophy, yes.
Atrophy
The
is something which is
only
going in
odd
front.
thing for Behçet's for me is the gender because
Yeah.
most patients of Behçet's are males. So apart, if you leave the gender out, a lot of it seems like Behçet's to me.
And how common is Behçet's in India?
Sir,
It's common in Turkey, but how common? How many patients we see often? I just want to know.
Sir,
I have seen one patient in my 50 years. What about you?
Sir, we've had 10 in the past year and a half. So
Okay.
I think it's a little maybe the Turkish belt is going through us to the Brahmaputra. So
Okay. Yeah. Okay.
Just one point here, like
Yeah,
as sir said,
Anuja.
like that involvement is like typical infratentorial brainstem pontine involvement, that is classical, and MCPs also was classical for Behçet's. But again, HLA-B51 is kind of just a genetic marker, and Southeast Asian population especially, like we'll see carriers of HLA-B51 natural, like it's kind of physiological carriers also. So just like, will that one marker be sufficient for us to like put our bets on?
no, Dr. Anuja, what I felt was that because, as has been discussed, it is predominantly brainstem with atrophy, with relapses on nearly everything that has been given, with the absence of supratentorial involvement, that is the only thing. And as you rightly said, because HLA-B51 can just be a red herring, it is not a part of the diagnostic criteria either for Behçet's or neuro Behçet's. So it's just
Exactly.
something that adds credence to maybe a thought that Behçet's may be considered. That is all that I was trying to say.
Totally
And
agreed.
only DMT which has not been used is the anti-TNF alpha. That is the so
We still have something left to
we
try.
have some options available. Dr. Yashwant, please.
Yeah,
Please.
one point, sir. Clinically, there were no ulcers. What we need, neither the oral ulcers nor the genital ulcers. That for basis we need them, isn't it, sir?
Uh, Dr. Praveen, so if you're
Yeah.
making a diagnosis of Behçet's disease, yes, you need it. But according to literature, most patients with neuro-Behçet's don't have the classical Behçet symptoms, at least to begin with. I agree with you that the patient has been suffering and is having CNS relapses for over a decade, and still none of the systemic features coming in is a little odd. But we've had patients come in with optic neuritis, eventually being diagnosed with Behçet's. We've had patients coming in with CVTs, eventually getting diagnosed with Behçet's because of subsequent treatment failures and SWI showing blooming and things of that sort. So just keeping it in mind, since the patient is not responding to everything else, that is the only thing that I was trying to put in here.
Yeah. Thank you. Thank you.
And Dr. Praveen, actually, to mention one of our patients actually who was not responding treatment resistant, they went to AIMS and Ayush only diagnosed it as Behçet's later on. Ayush, you did it. You remember that case, right?
Yeah, yes.
Yes. So that is the point. And now after infliximab, that person is perfectly fine. So I think there only we started learning again and again, and Ayush reinforced that this is all epiphenomenon. Sometime that we are what we can we are.
So Manish, what was the initial diagnosis?
Again, sir, it was the optic neuritis to start with, and then the brainstem syndrome, where we started thinking about shits. But because of the financial constraints, they went to AIMS and luckily met Ayush there, and then he made a diagnosis of Behçet's. And then after starting infliximab, he's on constant follow-up with us, but now doing well on infliximab.
Good, nice. Yeah. Please go ahead, Ayush. Sorry.
No, sir, I was just going to say that's why something that I've been taught by Padma ma'am, if you're looking at any patient with demyelination, after you look at T2 and flare and you think that this is demyelination, look at SWI sequences once to be sure that it is not vasculitis mimicking a demyelinating syndrome. So that is the only thing I was wanting to add. Dr. Yashwant, please continue.
So 1 minute, Dr. Ayush. That's a good point. So what do we look for in blooming in the
Yes, sir.
SWI? You want to look for blooming, thinking that it may show us the venous involvement or any hemorrhages,
Yes,
right?
so we frequently find blooming, sir, and the blooming typically in Behçet's will be present in the areas that are showing flare hyperintensity. And if you're finding it in areas that are not showing flare hyperintensity, the patient may have primary CNS or a systemic vasculitis as well. We've had so many patients come in with a diagnosis of tumefactive demyelinations or seronegative demyelinations who have had blooming and then DSA has been positive for vasculitis and eventually getting treated. So it's something that even for patients who have a longitudinally extensive transverse myelitis, we tend to screen the brain as well. And in the brain screening, apart from looking for white matter changes, we also look for blooming on SWI.
What was more disturbing was to know, sir, that this lady received this cyclophosphamide so early, but very poor response to that. Because most of the vasculitic, I hope you will agree with me that most of the vasculitic processes, they do respond to cyclophosphamide, at least transiently. They should have. She received 7 cycles, as Dr. Yashwant mentioned.
Yes,
So
7 cycles.
so slightly, maybe we can add on why, and we can see further how the things are. Please
go on, Yashwant.
Yes. So currently, this is the gait of the patient, sir. It is wide-based gait with truncal ataxia and stiffness of the left lower limb, as we can see in this video. And she is totally walker dependent. So these are the current differential diagnosis what we have kept, MOGAD versus neurobeshettes, and our current plan, that is comprehensive re-evaluation with MRI, brain, optic nerve, and spinal cord with contrast, MOG titers, and also we would like to evaluate for genetic diseases also, sir. And if the MOG cell-based assay turns out to be positive, then plan to escalate with newer agents like certolizumab or inbelizumab. And these are the red flags which were against the diagnosis of MOG in our case also.
No, but Yashwant, you talked about, go to the previous slide, please. Why do you want to consider spinocerebellar ataxia?
Sir, the long course, long duration, and highly resistant, which was too resistant to immunotherapy, significant atrophy involving predominantly cerebellum and brainstem, sir.
Yeah.
But some
I
risk.
know we discussed it in the morning, but later on, after you left, I was just thinking that probably that radiology will not, radiology atrophy may support it, but those hyperintense lesions probably, what do you think, Dr. Manish, those hyperintense lesions, can they go with? Can we still
No,
think of spinocerebellar ataxia?
no, sir, I don't
Really? Not really.
think that they go, especially these response to steroids revisions which were there. Dr. Praveen wants to add, sir.
Yeah, Praveen, please.
Sir, just wanted to make a point, sir. We had an extensive discussion with our radiologist also. Would you like to add, Yashwant, or shall I talk about it?
Yes, sir. So we have discussed with our radiologist, sir, neuroradiologist. So he opined that the exclusive dentate hyperintensity, what we can see in almost
Show
all
that.
of the films from starting here. So this dentate hyperintensity, what we can see in almost 2015, the 2018, even in 2019 and 2022, the predominantly only the dentate atrophy along with the peridentate area is involved. So SCAR20 and SCAR27B, in both of them, dentate hyperintensities were seen according to literature, sir.
And optic nerve involvement?
Optic nerve hyperintensity has been there in SCAR, sir, but steroid responsiveness is quite against SCAR, sir.
Yeah.
So, Yashwant, Dr. Mahajan is right. The present relapse includes optic nerves, correct, as a presentation.
Yes, sir.
We could get optic atrophy
Yeah.
in the later stages of scars and other diseases. But here what you have just now, from what I gathered, the last relapse was a vision loss, isn't it? The patient has
Yes.
come with vision loss. But that is not so common. Certain scars, optic atrophy, vision loss, that will go on over years.
Yes, sir.
There won't be a subacute event with optic nerve. And then you showed some enhancement around optic nerves, correct?
Yes, sir.
That Dr. Mahajan discussed. That wouldn't be seen with, at least as much as my knowledge, this wouldn't be seen with a degenerative condition. That should go for any inflammatory pathology.
Sir,
I don't know.
here I went through SCAR27B specifically.
Uh-huh.
Here it has been suggested that there are intermittent, established, sometimes attacks lasting for minutes, hours, and days.
Lakshmi, I'll call you back.
Attacks of what?
Attacks, whatever the attacks, they can be vertigo, oscillopsia, gait ataxia, dysarthria. They all, as
And
we look at in,
corresponding to that, those attacks, you get contrast enhancement and hyperintensities.
sir, our patient never had a contrast enhancement of the lesion, sir. The optic nerve, there was just a hyperintensity within the optic nerve, sir. We didn't see a good amount of enhancement in the first scan also. And one more point, the CSF 8 times, all time it is normal, sir.
Normal.
That was the biggest thing that made me look into it. And after discussion, the thought was that are we going in should we widen the horizon, sir? That's the point, sir.
Point taken.
Again, that optic atrophy can also, like sometimes too much of atrophy, the peripheral sheath can show some enhancement just because of the dye leakage also. So
Okay.
kind
Yeah.
of like that atrophy, bilaterally symmetrical lesions and significant cerebellar atrophy. If even if not scar, like at least any mitochondrial or so could be on the
Yeah, I would
differential
Yeah.
list. Just like
Dr.
I would
Yes.
think
Ayush,
so.
non
Dr.
Mitochondrial
Ayush.
versus a leukodystrophy
kind of.
rarely presents with,
Yes.
rather than progressive presence as sort of subacute events where they progress and then they stabilize, progress and stabilize. These are the two thoughts coming to my mind.
Dr. Ayush wants to say something. Yeah,
Yeah,
please.
Thank you. I have I'm a bit skeptical in considering SCA for the simple reason that there has been some response to treatment. Like the first time you said there was 80% response, then some 60% response. Then some MRI showed some small hyperintensity in the lateral part of the medulla, optic nerve. So all of that usually not seen in SCA. With regards to SCA 27B, I think we have around 6 or 7 genetically proven cases, and they usually present with episodic ataxia, and vertigo is a prominent complaint. When you examine them, there is usually vertical gaze nystagmus and vertical gaze extraocular. The saccades and the pursuits are involved much more than the horizontal ones. So there being no episodic ataxia, no vertigo in the patient with all of these changes in the MRI with response to treatment and the age. SCAR27B is usually seen in the latter part, 40s, 50s. It's a late onset cerebellar ataxia. It's not an early onset cerebellar ataxia. So I would be skeptical in considering SCA, especially SCA27B. And another thing is that MOG is a relatively recently described entity, right?
Yes.
NMOSD is much older, and now we say that NMOSD has autoimmune associations in 1/3 of the cases. According to the recent paraneoplastic criteria guidelines that have come, if you go through them in detail, you'll find that aquaporin 4 antibody is even classified as a paraneoplastic antibody because they say that if NMOSD aquaporin 4 is positive in the elderly, let us say above the age of 50, please look for a malignancy association because rare cases of ovarian cancers are reported with aquaporin 4. So maybe there are other associations with MOGAD that are still not described. Very recently, there have been publications about leukodystrophy patterns with MOGAD. I think there are 3 or 4 papers that have come out where patients had leukodystrophy-like presentation, were found to have MOG antibody positivity, treated, and some part of the cognition improved. And the explanation given was that just like Adam happens, the antibody reaction is very slow, so they keep accruing deficits slowly. And most of these patients with a leukodystrophy-like pattern were teenagers. So we really don't know as much as we think we do about MOGAD. And I think this case may have an association with Behçet's. I'm not denying that this is MOGAD. I'm saying that this could be MOGAD with Behçet's or MOGAD with something else, which you may find in the coming days. And you should definitely publish this so that people know that this association of MOG is also there.
So Ayush, previously we used to think that aquaporin has got a very strong association with Sjogren's and other. The same thing is being said with Mogard also, no, right? That's what you're saying.
Sir, I'm saying that like for aquaporin 4, it is described in literature that 1/3 patients will have concomitant other autoimmune diseases.
Yeah.
With
So
regards
same
to
is true with
Mogard,
Mogard, no?
yes, sir,
Maybe
but
less.
not
Sir,
as
it's not
as
so well described.
yes. So we occasionally see SLE, we occasionally see Sjogren's, but 1/3 definitely not. So maybe there is association with Behçet, there is association with something else which we still don't know.
Correct.
So one more point I wanted to discuss, which we took note of, is that they have particularly mentioned the word used high titers. And as you see the Mogard literature, they say that low titers have no value. Low
Correct.
titers can be found even in general population.
Correct.
Yes.
But
Even
high titers is, yeah. But can high titers also be falsely positive?
Sir, according to literature, no.
Seldom.
And that's why I believe that the patient definitely, the onset being in the teenage years is also something that goes in favor of MOGAD because amongst the autoimmune diseases, it is one of the most common ones to occur in childhood. So, but I feel that this may not be just MOGAD alone. There may be a concomitant autoimmune disease in the
Absolutely.
background, which may require something else, maybe escalation to a TNF alpha, maybe escalation to satralizumab or eculizumab if avoidable, and maybe that is the answer.
So
Now,
several things.
now,
So one point I
yeah,
want to
please,
make,
please,
Saul
Sripath,
sir.
please.
Saul sir, as Ayush rightly has pointed out, so about the mock titers, cell-based assay, obviously, it, uh, if possible, I mean, it's not possible commonly, but alive is the best. Then the fixed cell-based assay. ELISA now we don't approve of. And then if we read the most recent 2023 biannual criteria, mock titers along with the classic syndromes that are described along with MOGAD, if they go hand in hand, then there is no doubt about it. Again, it's like MS. You apply the criteria and try and to watch for its sensitivity, specificity in a scenario where it is not, the relapse doesn't look like MS, then you will be caught. But if the clinical radiological syndrome is classic and the mock titer is very high by cell-based assay, then yes, that's very useful. But if there's absolutely nothing suggestive of MOGAD clinical radiologically, and for whatever reason, I mean, first of all, you should not send. And if it is sent and if the mock titers are found positive, then they may not have any relevance. Ayush and Dr. Mahajan, am I right?
Sir, that is what I was mentioning, that I think Ayush also mentioned about doing CSF MOG titer. So this has got both not only diagnostic value but more of a prognostic value, because we have discussed this time and again, if there is a concomitant CSF and serum MOG positivity, then the prognosis is unfavorable then as compared to the just isolated serum seropositivity for mock titer. So seeing the type of response to immunomodulation which this lady had, so from the so long, if CSF MOG is planned or is done, that will add to value to the prognosis of this case also. And secondly, Dr. Yashwant, you mentioned that there is bilateral involvement of the optic nerves, right? If I'm not wrong.
Yes, sir, in this image.
So, dear, what we should be doing is that here we should not be using the word RAPD, because usually RAPD is usually done for the unilateral involvement. Okay.
Yes.
Yeah. So RAPD is not there with bilateral involvement. Okay.
Yeah. Yashwant, now as far as the current position is concerned,
Yes, sir.
does she have an acute attack at this time? When was the latest acute
The
attack?
last attack was 5 months ago, sir. It was visual blurring, which lasted for around 2 weeks, but she didn't receive any treatment at that time.
Now, how much she recovered? Did she recover at all from that visual blurring or no?
She was telling almost now it's clear, sir, with the help of glasses.
Yeah, so some of her, but her residual deficits continued to be there.
Yes, sir.
But this latest deficit is has also recovered, so it makes sense
Yes.
to give her therapy to prevent any future, events. Because since it's 5 months, as recent as 5 months back, so that means some activity. But she did recover from.
Yes, sir. She did recover.
Okay, please go on. Do you have anything else, or your case
There
is
is
over?
one point.
Yeah, please, Sripath.
Praveen wants to say.
Sir, regarding that RAPD, if there is a asymmetric involvement of the optic nerve, even if there is bilateral involvement, can we get a RAPD?
Yes, you
Because
would.
in this patient, there was the right eye was reacting very slowly when we compared to the left eye, sir.
Yeah, usually
You have a point.
it can
Okay,
come, but it is difficult to appreciate so quickly on the clinical examination. If there is because it's more like it's a clinical test for what we do with the VP, right? So it's all about neurotransmission. If VP is bilaterally prolonged, we expect the RAPD not to be there. So that's the big simple
But
point
Dr.
for
Mahajan
this.
is right. If there is asymmetric, if there is a severe asymmetry in the visual loss, then you could still get. I mean, if the transmission from one nerve is much delayed as compared to the other, you could get a mild RAPD. Now,
Okay,
there's
sir.
one
Thank you.
point. I have a similar case. I think it's in publication now, who again had a always a 6 relapse, left pons and middle cerebellar peduncle, MOGAD positive. And in the end, there's one point, the point I wanted to make is one point where the relapses stabilized, and that was maintenance IVIG. In addition to the maps that Dr. Mahajan and Dr. Agarwal mentioned, in our patient, we didn't think of the higher MAP like Sartrali and all. First of all, availability and constraint. But with few doses of maintenance, monthly IVIG, not at 2 grams, but at say 1 gram per kilogram, this particular gentleman has stabilized. That's
Right.
one point I wanted to make.
Sir, I think they gave IVIG and she continued to relapse on IVIG.
Yeah,
The-
tried IVIG.
They have used IVIG
Yes.
Yeah,
as
sir.
They have
maintenance
used.
therapy.
Yes, sir.
Yeah.
They showed that. That is why I did not bring it in because they said that they gave IVIG in monthly doses and the patient
To
continued
recover the relapse.
Yes,
Here
sir.
it's given
Yes,
like
sir.
monthly or 2 monthly to prevent further relapses.
No, sir. Actually, she received IVAG after cyclophosphamide, sir. After cyclophosphamide, she didn't got any relief. So IVAG was given in this time, sir. Around 6 months to 8 months, IVAG was given, sir.
Regularly.
Yes, sir. Monthly was given. The
She's
first
already
with
received it.
relapse to 2 gram per kg was given. After
Fantastic.
that, monthly was
Fantastic.
given, sir.
Great, great.
Yeah, Yashwant, carry on. Is there anything or you are done? Acha, current management.
After that, review of literature is there,
Red
sir.
flag. No, red flag.
So red flags we have discussed. Just
Okay. So do we, no, before I go for, we have now a few important points for discussion. It is 6:20. So Ayush, we finish at 6:30, right? We have 10 minutes. Is that right?
Yes, yes, sir.
Okay. Now you see there's one very important twist in the tale, which I have reserved for myself, which I'm going to. After Sripad and myself, and I think probably Manish also, you briefly came to Lekha Pandit's meeting in
No, sir. I was not there.
Mangalore. Okay, yeah.
No, sir.
Anyway, so we had very important lesson was given to us about cell-based assay. That's why Sripad, you today you noticed he at least 5 times said cell-based, and we agree with you. So what I did is that after I came back, I wrote a memorandum of understanding with Lekha Pandit so that we can give cell-based assay from our hospital only. It goes to Mangalore and it comes at a very reasonable price. So I think she was the first patient whose cell-based assay for Mogard we sent. And the report also came. And I'm sure you are waiting to know what the report said. And the report showed it's negative. Now, what does that mean? Does it mean that she is not active in this stage? Or does it mean she doesn't have Mogad? Or does it mean that we have to do CSF Mogad, cell-based? So over to you.
Sir, I'd like to start with the answer because I have two things to say here, sir. One is that if she is negative by cell-based assay, and I think Dr. Lekha Pandit's lab does a live cell-based assay.
Yes, live. It was sent live. Yeah.
Yes. So then the test can't be discounted, and either the patient did not have Mogad, or the other possibility is also because she's got so much of immunosuppression. Mogad is known to turn negative with immunosuppression. Some studies have even shown that if somebody has Mogad and their antibody status becomes negative, you can actually plan de-escalation or stopping immunotherapy because such patients are unlikely to relapse. It's a policy that we follow here that after 2 years of treatment, I tend to repeat a MOG antibody test. And if the test is negative, I offer to the patient if they want to stop treatment, most of whom agree. So it may be either of the two, but based on the discussion that we've had in the background that this could be Behçet's, I would hereby feel even more positively about a diagnosis of Behçet's in this patient.
But would you want us to do a Yashwant? We sent serum Mogad.
Yes, sir. Serum
So
Mogad.
would you suggest to us to send CSF Mogad also?
Definitely, sir. Because
Okay.
isolated CSF positivity is also described. And as Sripad sir was talking about the Banwell's criteria, she fulfills that criteria. She had a classical brainstem syndrome with MOG antibody positivity. So nothing against, and even if it is negative, I would still feel that she had, or rather has MOGAD, which has turned negative, and she has a concomitant another autoimmune disease. I would not say that she never had MOGAD because there are too many things in favor of the diagnosis than against.
Correct.
Yeah.
Just one doubt about that, seroconversion part. She had, I think so, latest attack was around 4 weeks ago.
5
And
months.
as per his
Not 4
notes,
weeks,
at
4
least
months
5
ago.
months. 5 months.
5
5
months ago.
months.
Yes.
Okay. And treatment was stopped, I think so, in 2022.
No,
Back
ma'am.
then,
From
exhausted also.
2022, she is on prednisolone 20 mg once daily and azathioprine 50 mg once daily. So they just
Once
titrated
daily.
themselves and they're just using one tablet each.
But despite that, she had any attacks in
Yes,
between
ma'am.
this also,
In
2022 till now.
2022 was the last attack while she was receiving sixth or seventh dose of tocilizumab. After 2022, it was just 5 months ago, the recent
like,
attack.
the disease has remained active, and that's
Uh,
not kind of an optimal therapy, at least for the last 2-3 years at least. So like, can the titers which have been in such a aggressive disease go down despite not receiving optimal immunotherapy and the
Anuja,
disease
it has
being
not
active?
been aggressive. I mean, if I 22 to
Yeah.
till
Yeah,
5 months ago, it has been relatively quiescent with the 20 milligram of prednisolone, whatever
okay,
other therapy. So there has been periods of quiescence, and the distance
okay,
between we performing cell-based to the relapse has been 5 months. So if you're too away
right.
from the relapse, at times the MOG may have dropped down. And then I continue what Dr. Agarwal Ayush was emphasizing. The titers may again start rising just a few days before relapse and continue during and a few weeks after relapse. And if you give aggressive immunotherapy, the titers may go down after a few months.
So, sir, can I ask one question?
Yeah, Manish, please.
Yeah, this is to Ayush actually. So, Ayush, would it be prudent to do CSF GFAP over at this point?
Can do CSF GFAP, but despite so many
No.
attacks, there were no radiological findings to suggest GFAP, CSF.
No, even for the activity of the disease. I'm saying.
Activity.
Okay. GFAP as well as neurofilament light chain can be done if cost is not an issue. And to add to just one line to what Shripad sir was saying, I like that this slide is open right now as you're discussing this. Treatment with high dose corticosteroids. So she was nearly on 0.4 to 0.5 milligram of oral steroids for the past so many years. That is, and MOGAD will respond to steroids a little bit. So this further adds to the possibility that because of the steroids for the past few years, the MOGAD antibody status may have turned negative.
Yeah.
I would love to see a recent, my thing would be before you go on to do these serological markers for disease activity, just get a recent 3 Tesla MRI and look at
Yes.
SWI and all other sequences to see how the brain is acting.
Actually, we got the report of cell-based yesterday only, sir. So we have called the patient to come for visit, as well as we want a imaging also, sir.
This was
We have done for
Subhash sir's oversight, where he knew that there will be a twist in the tail that comes in before the patient.
Yeah. No, I think we have taken all your inputs, and thank you so much, Ayush, for giving us this
Sir,
opportunity.
Paul sir, there is a
Yes,
question, sir.
Praveen.
There is a
Praveen,
question
please.
answer, sir, in the chat box.
There
Shall
is-
I
Okay,
answer
okay.
it, sir?
Then, yeah, please.
Yes, we had considered clippers, but looking at the MRI, clippers was ruled off. Definitely.
No, please read the question and please give the answer, Praveen, please.
Yeah. The thought was that did we consider any other differentials?
Okay.
Clippers, neurosarcoid, and Sjogren's. Yes, they were definitely thought of, but looking at the MR, clipper was out, and definitely sarcoid, as we know, you should have a good amount of nodular enhancement. That was not there at all. Therefore,
Yes.
but yes, they were all thought of. But after a good consideration, we removed all of it, and we just kept about Mogad versus Behçet's.
Yes. Any other question in chat box?
No, sir. Only one question, sir. Only one.
So, Ayush, I have to thank you very much for giving us this opportunity. And thanks, Dr. Manish. Thanks, Shripad. Thanks, Yashwant. Yashwant was little, in the beginning, he was saying, can I really present it? I said, it's a very friendly panel. We'll discuss. And I'm sure you are, you agree with me. Thank you so much for giving us the
Very well
opportunity.
presented.
Thank you, Dr. Anuja, for pitching in. I don't know what time it's in US right now, Anuja. I think he has left.
She's there, sir.
Yeah.
We are
I am
on
here.
mute.
I'm here. Sorry.
Anuja, what time
Morning.
it is there?
It's now 8 o'clock. We started at 7. So thank you. But no,
Okay. Thank God it's
very
not
nice
1 o'clock in
discussion.
the night. That's the problem with US. But thanks
Thank
for
you.
thanks
Thanks
for
a lot,
joining.
sir.
Thank you.
And
Yeah.
Praveen, thanks
Thank
for.
you.
So
Thank
Ayush,
you.
any words? Manish, any words from you? Final words?
No, sir. It was a great discussion, sir. Great learning, sir, from all of you. Thank you so much for involving me in this. Thank you. Thank you, Dr. Shripad, and thank you, Dr. Ayush. And always a blessing to be with Dr. Subhash, sir.
Thank you, sir.
Thank you all for joining.
Thank you.
I'll hand it over to Shripad sir for last word. before we close?
So I thank all my panel, the presenter panel, and the discussants for bringing out so many points in relation to inflammatory diseases, more so MOGAD, Behçet's. So really a lovely discussion on methodology of performing the assays, the clinico-radiological criteria, other differentials, combined immunological diseases like aquaporin disease. So much to learn just from a single case, and such a long case it was, and still I think fairly well managed so far. And I'm sure in hands of Dr. Kaul, Praveen and others, they will take it further. Thank you.
Thank you.
Thank you.
Shripad sir,
Thank you so much.
on
Bye.
his behalf, I'll say we have ICTRIMS next month in
Yes.
Pune, being hosted by Shripad sir.
Yes.
Yes.
All are welcome.
A grand success.
Yes.
Thank you.
Thank
See
you.
everybody
Thank you,
in
sir.
Pune. Thank you. Bye.
Good night.
Good night.
Good night.
Thank
Thank
you.
you.